welcome for your first session of the day with Dr. Kathy Saw. Dr. Kathy Saw is going to talk about the use of artificial intelligence in IPAC. Dr. Saw is an infectious diseases and infection control physician in Ottawa, consulting staff in the Division of Infectious Diseases at the Ottawa Hospital, and a professor of medicine at the University of Toronto. She was previously the medical director for infection prevention and control at the Ottawa Hospital. Dr. Saw is the physician director on IPAC Canada Board of Directors and is a medical advisor for Correctional Service Canada. When she's done presenting, we will have hopefully a few minutes for some questions, so you can put those in the Zoom chat and not the feed loop chat, please. Dr. Saw, over to you.
Great, thanks very much. Just one minor correction: University of Ottawa, not University of Toronto. We were just talking about the Blue Jays.
Just talking about Toronto and Blue Jays.
So anyway, thanks very much. I'm happy that all of you were able to attend so early, and thank you to the conference organizers for asking me to give you this session. I'm happy to be here. My only regret is that I'm not actually somewhere in Nova Scotia or the Maritimes right now. I have no disclosures. I will say this presentation was not created or developed with AI. I will give you some warnings, though. I'm not a subject matter expert on artificial intelligence, so you may wonder, how did she get here? And in fact, I think that adds some perspective because I can try and share the user view on artificial intelligence and an unbiased opinion about how this can help us in our profession. I do use two terms in this presentation. One is accuracy, the other is OROC, or area under the receiver operating curve. I'm using them interchangeably, though they're not exactly the same, but the area under the receiver operating curve really is a measure of how well a computer model can discriminate between two discrete outcomes. So 0.5 or 50% is randomly, and 1.0 or 100% is perfectly. So the higher the number, the better the performance. And I do show some examples from corporations and organizations that are just examples, so I'm not endorsing these at all. If you have questions, please feel free to post them. As Angela said, I can either take them in real time or we can have a question period at the end. So I have 4 objectives for this presentation. One is to enable and to provide you with a basic understanding of artificial intelligence. The second is to review some of the potential uses of artificial intelligence in IPAC. I also want to just briefly touch on the use of artificial intelligence in related fields that we work with all the time, but are not specifically IPAC, and then really highlight some of the considerations and challenges for implementing artificial intelligence in your workplaces. These are the areas that are out of scope. I'm not going to discuss the clinical diagnosis of infectious diseases, prediction of clinical outcomes other than some examples for healthcare-associated infections. I'm not going to talk about the use in clinical management, but recognize that all of these are related to what we do every day in some manner. You should all be familiar with the competencies and roles for infection prevention and, infection prevention control professionals. This is from the IPAC Canada standard core competencies. And I have just summarized what I have always considered to be really the primary roles and activities. Now, I do have a bias, which is that largely my experience is in large acute care academic centers. And so I recognize that perhaps not everybody who is attending today will necessarily be involved in all of these activities. But these also highlight some of the areas where AI can actually help us to streamline our work and to help enhance what we do. So first, I'm just going to start with, what is artificial intelligence? So there are a couple of definitions. Some of you will recognize ChatGPT on the left-hand side here. The Oxford English Dictionary defines this as the theory and development of computer systems able to perform tasks that normally require human intelligence, such as visual perception, speech recognition, decision-making, and translation. Okay. IBM says that artificial intelligence is technology that enables computers and machines to simulate human learning, comprehension, problem-solving, decision-making, creativity, and autonomy. So fundamentally, it's trying to, have computers work and behave and interact as humans. There are different types of artificial intelligence. This is really a very brief overview, but you may see some of these terms if you are reading more about AI. Narrow AI is really task specific. So Siri, if anybody uses an Apple phone or Apple products, self-driving cars, computers in those instances are set up to do one specific task. There's general AI, which is AI as I just described it. What we really focus on when we're looking at applications in healthcare is machine learning and also deep learning. So machine learning is trying to have computers have a simulated brain. So they call those neural networks. Machine learning is superficial. Deep learning has much more complicated neural networks. And so it really is trying to integrate input and produce output on many levels, just as we would do as people. There is supervised machine learning and unsupervised machine learning. I'm not going to touch on those today. And then there's generative AI, which is really like ChatGPT, which takes input and develops new output, either written or speech or in images or videos. So this little graphic here just really shows these concentric circles with neural networks and deep learning being at the center. So those are really what we're focusing on today, although there will be examples of other artificial intelligence methods briefly discussed. When we look at computers and how we program computers to produce results, this is on the left-hand side, sort of classical programming. So if anybody has done research using a database, you have this set of data, you develop the algorithm for the computer to use, and it spits out whatever results you're looking for. So it could be taking a database from an electronic medical record and developing an algorithm to look for risk factors for breast cancer, let's say. Okay, so you get those as the output. What we are doing with machine learning is we are taking those data, we already know what the output is, and we are trying to basically look at this backwards so we can have the computer develop an algorithm for us, which can be reapplied to data sets as they grow over time in different populations. Okay, so it really is a different application of computer programming, if I can call it that. Everyday examples of AI, I mentioned some already: Apple Watches, virtual agents. Weather forecasters use AI all the time for predictions. I think with the last hurricane, you could see there were no predictions because there were like 100 different models that were showing 100 different routes of the most recent hurricane. And then ChatGPT and Copilot, which some of you may use in your day-to-day work already. So this is just a slide taken from this reference at the bottom that really highlights where in healthcare we can use AI. So for diagnostics, personalized medicine, so individual medicine, case by case, virtual assistants to help people with directions or information, decision support, drug and vaccine discovery, patient scheduling, administrative workflow, and then definitely not going to touch on this today, robotics and robotic surgeries is one example. So what are some of the uses that are coming into the infection prevention and control world? So before we all jump on the bandwagon for AI, I think we really have to be clear about what we want it for. So these are not easy systems to develop, and you really have to consider what is the value of all of the human resource and expertise and cost that is going into this versus what will come out at the end. So be very clear about what it is that you're considering when you are thinking about implementing AI in your workplace. Okay. Investment can be huge. So you do need IT expertise, you need computer programming expertise, you need obviously our expertise as infection prevention and control, and often a lot of money. And you can develop these, you can implement them, but they also need to be upgraded and maintained on a regular basis. And I'll get into that a little bit later. Data sources and quality will impact performance. So we're all familiar with the term garbage in, garbage out, which is very true. And not all of our databases and our electronic records speak to each other in the same way. Not all of our lab values are exactly the same. We don't report results in the same way. So all of these things can impact the generalizability of AI programs and algorithms. They do need to be tested and validated and continually adapted to stay valid. So, as an example, if microbiologists, sorry if there are any microbiologists out there, are just famous for changing taxonomy all the time. So let's say Staph aureus changes its name to, let's diminish it and say Staph argentis, silver instead of gold. Well, then you've got to make sure that all of your programming has taken into consideration this change in taxonomy or change in lab values. And so while this technology can help us, I think we're still at the stage in IPAC where we could be partially automated, but not fully. Okay, so we still need people. But we can use AI and IPAC for some simple things: clinical decision support, education and feedback, environmental cleaning and disinfection. There is some evidence for its ability to predict healthcare associated infections. Surveillance is a huge area where I think AI can definitely help with workflow, and then also outbreak identification and management. For clinical decision support, I think most of you are probably familiar with this, but this is, you'll see the date on here, 17/12/2020, so in the middle of the pandemic. This is from our Ottawa Hospital EPIC. And you can see here that I'm screening somebody who's presenting to the emergency room with symptoms that might be related to COVID. Have you been tested? Why were you tested? Da, da, da. And the computer or the algorithm will take into consideration the answers that you provide, and then it will try and provide you with some guidance about what the best decision might be. So it could be treatment guidance. In this case, it's isolation guidance. So you fill in the questions, you get the automatic pop-up that says this patient may have COVID, and here's where you should place them, depending on where you are in the building. I think many of you are familiar with this type of technology. For education and feedback, this is one example looking at PPE training. This is from China. These investigators developed a model. So basically, they used video training of staff donning and doffing PPE to normalize what is the correct behavior for donning and doffing of PPE. So basically, they had a computer filming, hundreds, several, whatever, large numbers of staff donning and doffing PPE. And so they were able to train the computer to know what's the correct behavior and what's incorrect. And then they implemented this outside a donning and doffing station. This is in the pandemic. And if you made an error based on what the computer had learned was correct methods and incorrect methods, it would talk to you. It would say, stop. You need to put on your gown, or, you have applied a procedure mask instead of an N95 respirator. And so it would talk to you and give you real-time feedback. There was an education and evaluation program that was developed. These investigators are trying to demonstrate that before the implementation of this AI system, they had 52% compliance with PPE donning and doffing, and that after they implemented it, it went up to 98%. They also tried to link this with a reduction in healthcare-associated infections. Note the date, though. So there were a lot of other things going on in 2020 that could have accounted for a drop in healthcare-associated infections, which were not specifically elaborated on in this paper. Environmental cleaning, again, robots in environmental cleaning, not uncommon. On the left is iRobot that some of you might have in your homes. On the right, of course, are two examples of ultraviolet robots. They can be trained to read the environment and know where to go in a room or a space to clean or disinfect properly. So they work well. They can reduce colony counts in many papers or studies. like many of these examples that I'm going to show you today, we need real-world validation. So does this actually reduce healthcare-associated infections? When you look at how we predict healthcare-associated infections currently, on the bottom here, this is a nice graphic, but this is the typical course of somebody who's admitted to a hospital or even perhaps a long-term care home. So you get admitted, you're in the organization, you get some treatment, whoops, you develop an infection, perhaps you're incubating, then you develop symptoms, somebody needs to recognize this, you need a test, and we diagnose the infection, and then you get treated. Okay. So when we're performing our surveillance currently, typically we only know about the healthcare-associated infection after it has occurred. And what machine learning can help us with is trying to predict who will actually develop healthcare-associated infections so that you can intervene before it actually happens. There's some neat examples of this. This is not a healthcare-associated infection example. This is from emergency rooms. This is in the UK. There are a couple of interesting points from this slide. So the first is that these investigators were trying to look at whether or not they could predict whether people presenting to their healthcare system would become bacteremic in the immediate future. So they were using data from 14 days prior to a blood culture being taken to try to train their computers to see how can they predict who's going to develop bacteremia, and not only bacteremia, but bacteremia with a pathogen. So like all of these AI machine learning systems, you need to train your computer. So in many data sets, there will be about 2/3, 3/4 of the patients who are used to train the computer, and then you validate your algorithm on the remainder. They used a couple of different methods, logistic regression, which is using one point in time, and this deep learning or machine learning method. And there are a couple of things that they found. One is that here, so the area under the receiving operator curve, or the performance, was about 75% for logistic regression, using a lab value, the lab value that they had that was obtained most recently within that 14-day period prior to the blood culture being taken. So clearly they're going to be missing data. People don't show up. They show up when they're bacteremic. It may be irrelevant information, but it might be very relevant, like a white blood cell count or increasing creatinine or a temperature. When they looked at their machine learning model, they found much better performance, so 97%. Okay. But they used measurements 7 and 14 days before the blood culture was taken. So really incorporating multiple points in time to try and use that to develop a better prediction model. So this is a key thing. The more information you have, the better you can predict. Didn't work very well for healthcare-associated bloodstream infections. They had some possible explanations for this, but this really was not what they were trying to determine in this study. There are lots of examples of surgical site infections. This is one that I had selected. This is from China, looking at hemicolectomies and trying to predict surgical site infections from hemicolectomies. And depending on computer programmers, they're developing all sorts of different models and using different combinations of variables. But they found their models worked 76 to 88%. So not bad, but none of these is perfect. So none of these actually replaces humans yet, recognizing that as people, we also make some errors occasionally. There are also Canadian studies that are similar. So the first, Petrosian, is from the Ottawa Hospital, actually using administrative data compared with NISQIP case review data. And then the two on the bottom are from Alberta Health Services in Calgary, looking at the detection of surgical site infections from cardiac device implantation and also from arthroplasties. And so you can see we can also develop pretty good models for prediction of surgical site infections. This is a really neat study because this is one of the few that has actually been validated prospectively. So this is a large study that was conducted at the University of Massachusetts and also the University of Michigan hospitals. And these investigators were looking at models that incorporated both time-dependent models or time-dependent variables, so variables that change over the course of, let's say, a hospital admission, and time-independent variables such as your sex, your age, your date of birth, the unit you're on. And they were trying to see if they could predict healthcare-associated Clostridioides difficile infections prior to the time that it was actually diagnosed. Okay. So they were able to train their computers to develop this algorithm that on a test cohort, so the testing group performed about 75 to 80% correctly. So they're still missing about 20% of cases. But the interesting thing that they identified is that of those cases that were correctly identified, who went on to develop C. difficile, about half of them could be identified 5 days prior to actually developing symptoms and being tested. So, if we were able to do that with more certainty, think of all of the possibilities, right? You could isolate that patient preemptively. You could stop their antibiotics. You could implement your sporicidal cleaning or disinfection earlier. All of these things that we could try to do to mitigate spread of Clostridioides difficile if only we knew who was going to get it. They did report in a subsequent study, that's the 2023 one here, that they validated this prospectively, and it worked equally well as their testing study. They also identified, and this is the second important point, that populations and facilities are not all the same. So they were able to develop a facility-specific algorithm, one for the University of Michigan hospitals, one for University of Massachusetts hospitals, that were slightly different, but that worked better for each of those populations. So they are not, they're not always generalizable programs. Then we look at surveillance, and I think surveillance is really one of the areas where we could really benefit from artificial intelligence as a time saver. Anybody who conducts manual chart reviews of, for surgical site infections or any other hospital-acquired infections will appreciate how long it takes sometimes to go through these charts. So this is one study that was published in 2024, just looking at development of two AI agents, basically. One was ChatGPT and the other was a home-developed model. And basically this showed, they took made-up information, entered the data into the platform, and the ChatGPT or the agent would take that information, assimilate it, analyze it, and come out and tell you, I think this person has a healthcare associated, in this case, it was lab confirmed bloodstream infection or not. Okay. Worked reasonably well, but again, not perfect. These had to be trained using standard definitions as well as local definitions. So, NHSN or CNISP definitions for what is a healthcare-associated bloodstream infection, what is a CLABSI, et cetera. Okay. But it's an interesting application. There are other studies that are similar. These two, however, are really just highlight the time saving for particularly surgical site infection surveillance. So in the study on the left in Korea, this was looking at data from 2013, 2014. So they had about 1,700 patients who underwent colon surgeries. Okay, and these were charts that were reviewed by their infection control professionals, and their historic rate based on manual chart review was about 5%, so 82. Okay. They then developed this rule-based system to flag potential SSIs using 3 criteria. So one was if antibiotics were ordered, the second, if an ID consult was ordered, or the third, if a culture was taken, there would be a flag that would indicate to the ICP, this is somebody who might have a healthcare-associated infection. So using that rule-based approach, there were 470 of these 1,692 cases that were flagged, and 78, compared with 82, were identified as having surgical site infections. They then went on to develop machine learning algorithms that picked up possible 266 cases, and of those, 77 had surgical site infections. So the accuracy of their algorithm was about 94 to 95%. So if you're willing to accept that margin of error, you can save a ton of time, basically. So they estimated that their chart review time was reduced by 84%. So, 20 minutes to review a chart, or 15 minutes to review a chart, you're reviewing 1,700 of them. That's a lot of hours. You can reduce that by 85%, save a lot of time that you can then use to apply to other things. Okay, similar study in Spain. I won't go into the details of that just for time, but it's a very similar principle. Then we have outbreak detection. So we can use AI for outbreak detection. This is actually a commercial program. I don't know if anybody's used this. I haven't. It's called Blue Dot, but this is real-time machine learning that is based on inputs from social media postings, public health alerts, animal health data, travel and airline data. This is Canadian, actually. It's based in Toronto. And there is one report that is cited here that demonstrated the potential spread of COVID by air travel. So basically, can you predict that it's arriving before it actually shows up? The next two slides actually are great studies, but not things that I don't think most sites in Canada are able to do this, because it incorporates the use of this extensive whole genome sequencing library with machine learning algorithms that try to identify links between patients for, epidemiologic links that you would look at in outbreaks. So this is from the University of Pittsburgh. They actually had collected isolates of all gram-negatives that they considered significant. So Pseudomonas is one, but there are many others, and performed whole genome sequencing on all of these isolates between 2016 and 2019. So, they have a whole genome sequencing lab. In Canada, we don't have this available to us as readily. Okay. They also developed machine learning algorithms to try and identify transmission routes of pathogens based on similarities of isolates and patient information that they had in their EMR. And so what they did when they applied this to Pseudomonas aeruginosa is they retrospectively identified a cluster of 6 cases who had related, identical, Pseudomonas isolates, and were able to implicate a gastroscope in transmission of this isolate over, it was a long outbreak, so it's 18 months to 2 years. But the important thing about this, and this happens, this had not been picked up by traditional IPAC surveillance, probably because the cases were so spread out over time that there was no confident way for the infection control team to link these cases over several months. So I think there was a hospital-acquired pneumonia, a few bacteremias, some quite severe outcomes. And if the argument of these authors was that if they had this system in place at the time that this was happening, they could potentially have identified the mode of transmission earlier, pulled the gastroscope out of use, and prevented 3 additional cases. So again, a really neat application of machine learning algorithms combined with data sets from whole genome sequencing. Same group in Pittsburgh, using the same method with whole genome sequencing library and machine learning, identified 99 clusters of possible transmission with 297 patients between 2016 and 2018. Okay. Machine learning algorithms identified potential transmission in 65 of these 99, and manual chart review identified 15. So again, are these all truly related? You'd have to go back and confirm that. But from a time-saving perspective, if you could identify these clusters in real time, you at least could focus your activity on determining whether or not there is a true outbreak. But based on the data that they had, they estimated that they saved up to or prevented up to 63 transmissions of infections and would have reduced readmissions and deaths and saved about, I'm going to average this, 9,500 American dollars for each transmission averted. So, this is something maybe we'll see in the future, not right now in Canada, I would say. And then last, AI for policy development. So this is with Copilot. I just put into Copilot, I need a hand hygiene policy for hospitals, and this is what it spits out. So remember, if you are using these to try and develop policies, they can be decent, but you do still need to review them because there will be points in here that are not accurate, that don't apply to your particular facility, or I suppose could just be wrong. Okay. So there are a lot of possibilities with automated surveillance, and I'll leave you with, you will get the slides. I will leave you with this slide, but it just really highlights many of the things that I've already tried to illustrate for you. In related fields, there's a lot of development of AI. So in the micro lab with antimicrobial stewardship, drug and vaccine development, maybe facility design, maybe other uses that are relevant to us, certainly in the public health realm, there would also be a lot of applications for surveillance in particular. So in microbiology, this is a review paper from this July, and many of these, they're just trying to illustrate really what is related to clinical microbiology where AI could play a role. And so not all of these boxes really contain things that I would typically classify as being clinical micro, but again, they're all related. But in the microbiology lab, diagnostics, so there's a lot of study on the use of AI in diagnostics. So can you train computers to read gram stains? Again, saves the technologist time from having to look under a microscope. There are studies that show that you can train computers to read plates, so particularly for urine specimens, which are quantitative. You can train computers to accurately not only count the colonies, but identify whether or not they are potentially significant. MALDI-TOF, which is used in many labs, is spectral analysis. So I'm not going to go into this, and I'm not an expert, but basically you can apply AI to an already computerized system to help enhance its performance and also provide some early indications of resistant pathogens from cultures. AMR is another, or antimicrobial resistance is another huge area where AI is becoming more and more prevalent. So again, using the MALDI-TOF system, you can apply AI and train machines to look at whole genome sequencing. Again, we don't have this readily available data, or other genetic libraries to try and identify resistance genes kind of on the spot so that you can predict whether or not an isolate that has just come up as a positive blood culture might be resistant. Clearly, that can help clinicians try and use the most appropriate therapy from the outset, which we recognize as being beneficial and reducing mortality. And then again, surveillance, which I just showed you in the outbreak slides, but also in the broader sense of surveillance, we can use it to understand better what is occurring globally in terms of surveillance. For antimicrobial stewardship, again, lots of use already. So the use of clinical decision support tools, or even simple things like, it's not quite the same, but forcing functions on computer order entry. We can use AI to help predict diagnoses. So is this heart failure or is this a pulmonary infection? If it's a pulmonary infection based on a computer read of a chest X-ray, does it appear to be bacterial or is it more in keeping with something that's viral? Should I start antibiotics or should I wait? Okay. Predicting antimicrobial resistance, again, I just went through that. And then also it can be used to optimize antibiotic prescribing. So, selecting empiric antibiotics based on, this is individualized healthcare, an individual's EMR. What antibiotics have you had recently? What resistant pathogens have been identified from cultures that have been obtained from you recently? How can a computer use that information to give you a decision support tool saying this patient might have resistant E. coli infection, and then you can make a decision about what the best empiric therapy is. Can also help with when to change antibiotics and also dose optimization for antibiotics. So there are lots of different possibilities there. And then the last thing, antibiotic or drug discovery in general and vaccine development, again, huge. Historically, drug development, antibiotic development has been very slow, as you know, and it takes an awfully long time to try and identify and develop new antibiotics. So historically, this has been based on lab identification of metabolites in nature. So, penicillin was an accident is one example. But there are now databases of chemicals, and there are databases of molecules that might have antimicrobial activity. And so these databases that we have of known molecules apparently is like incredibly small compared with all of the molecules and compounds that exist in nature. And so what you can do with AI is train a computer to basically develop this algorithm to take what it has learned from those compounds that, let's say, we know have antimicrobial properties and apply this to scan a whole library of other unknown compounds to identify what might have antimicrobial activity that we didn't know about previously. And so this has been used to identify compounds with activity against E. coli and also with Acinetobacter baumannii. There has been development of a new agent called Abacin, which was shown to be effective in an in vivo mouse model of Acinetobacter infection. These are Canadian publications, by the way. This group is in Hamilton at McMaster, so it's kind of interesting. I did read the publications. They're not the easiest to digest, but it just gives you a glimpse of what is possible. And similarly for vaccine development, we can really accelerate vaccine development, predict what antigens will be immunogenic. We can try and use AI to predict efficacy and therefore effectiveness of vaccines in real use. And when you combine this with nanotechnology, so really looking at tiny, tiny molecules on the atomic scale, this has the potential to really accelerate vaccine development, which, as we found with COVID, is now quite fast, but this could potentially make it faster. This is from the Pfizer actually homepage. So mRNA and artificial intelligence. So everybody's getting on the bandwagon. And then last, considerations for use of AI and the challenges in implementation in IPAC. So this is my slide that I made up, and I think the two most feasible uses right now would be for healthcare worker education and feedback, and also for surveillance. Okay, but clearly there are implications, and I've shown you these, right? Making spaces cleaner, predicting healthcare associated infections so that we can intervene early or ideally prevent these infections from occurring. Early diagnosis, okay, outbreak detection, and policy development. So I think there are many applications. I think we really, again, have to stop and think, though. So these all require human oversight. These are not perfect systems. So if you are using AI, this is a nice quote from Shea. Technology enables our work. It does not excuse our judgment nor our accountability. Okay. But we should try and, rather than try and push back against AI, think about how can we use this to enhance our performance, to make our work better, to make our environment safer for our patients. So consider the opportunities, but there are a lot of shortcomings that still need to be worked out. And again, back to the one of the earlier slides, you really need to prioritize what it is that you're trying to use AI for, and ideally get stakeholder input. Okay. So you are stakeholders, all of you who are here, but also frontline clinicians, frontline nurses, pharmacy, micro, they are also all stakeholders, as are patients. So considerations before you just implement AI in your organizations. I think data standardization and quality I already mentioned. We're a little bit short on governance and regulations. So there is a federal government bill, Bill C-27, which is the Artificial Intelligence Data Act, which is really meant to be applied to the private sector. That does outline some responsibilities and accountability for organizations using AI. Legal and ethical implications. So this is huge. Can your data be used in developing algorithms? What are the ethical implications? Who owns the data? So their personal health data, and there's personal health information that goes into this, but who's the owner? Unresolved. The costs I mentioned before, the resources I mentioned before, education. So I would say many of us, many of you in the audience, many of us where I'm working, don't really have a good feel for AI. So I think one of the first steps is really understanding AI and how it can help, not how it can put you out of a job. But that is obviously a concern for everybody in the workforce. Anytime we talk about automating something, am I going to lose my job? And so I will happily say right now, I don't think you're going to lose your job yet. But I should say, I don't think you're going to use your job because this still will require expertise and people to oversee it if we implement more broadly. So there is a lack of understanding about AI, and so there's limited uptake. And honestly, if you try and read some of these reviews, which I have given you a list of references at the end of this, they're very technical. They're written by computer scientists and programmers. And so trying to understand how AI works needs to be simplified for frontline users and also for patients. Until we're able to do that, there may be limited uptake or buy-in, particularly where personal health information is used to develop these programs. The costs I mentioned, they might be excessive. They definitely don't replace the human experience. So, as an individual, I can go talk to a patient, I can go counsel them. I don't think talking to a robot is going to be quite the same. They don't emote as one thing. It still requires humans for direction and oversight, the adaptability to changing healthcare practices, so even changing infection control policies that you might generate. If you are using AI to train healthcare providers to don PPE properly, and then let's say the sequence changed or the recommendations changed, you'd have to make sure that you can keep up with that. It's not really great for low incidence diseases or conditions with that are rare. So you're putting an awful lot of resources finding the needle in the haystack. I think this is really important. Most of the centers that use AI now are larger academic healthcare organizations or researchers. And so there are a couple of things that are relevant to that. One is that you need to understand that if you are trying to apply an algorithm that was developed, let's say at the Ottawa Hospital, okay, first of all, my patient population is not going to be the same as your patient population. So it may not be generalizable to your setting at all. In limited resource settings, this may be even truer. Okay? The other thing is when you look at the data that go in to an EMR, there are going to be some biases that exist in those data. So as one example, if I'm just making this up, so don't take this literally, but let's say I'm an oncologist and I don't treat patients over 80 with this particular type of chemotherapy, I'm not going to have those outcomes in this data set. So if you want to then try and develop this algorithm that has been developed in my center for who is going to respond best to this particular chemotherapy, you're missing that whole population. And so again, that is not going to be generalizable to other centers that may want to use this for older populations or pick a specific subpopulation. So I think we just need to be very aware of some of the biases of the data that are already in our EMRs. standards and regulations and the ethics of AI unresolved right now. I think there's a lot of discussion about this already. And for IPAC, it's nice to see that we are getting some real world validation, so prospective use of AI programs. But as you saw with the C. diff example and the SSI examples, they're not perfect. So we still need either, I would say, better performing programs and people to continue to do what we do as best as we can. This is a slide from, it's really small, I realize. This is from the Lancet Infectious Diseases. This just came out in September. It's available online only right now. But I thought it was a really nice summary of where AI can be implemented and used to enhance healthcare delivery. And if you look at this, unfortunately, settings like long-term care and other congregate settings are not specifically mentioned here. But if you look at this, this follows the patient's course through an institution for every single element of clinical care that we provide. So there is definitely potential for this. I didn't use AI to develop this presentation. I think that's pretty obvious, but just for fun, I did ask ChatGPT to give me an outline, and this is what it gave me. So I kind of hit a lot of those points, maybe not all of them, but it is kind of surprising. If you haven't used ChatGPT before, you should just put something in and watch it spew out the answer. It's kind of fun. So these are the 4 objectives in a nutshell. That was really fast, I know, but hopefully I have introduced some of you or reassured others about the uses of AI in infection prevention and control. And you will get these slides as handouts, so I do have some references for you. This is a nice series in the Lancet Infectious Diseases that just came out in September that is a nice overview of AI in health, infectious diseases. So that's it for me. Go Blue Jays. And happy to take any questions. I think we've got about 10 minutes.
Perfect. Thank you so much. That is really fascinating. I'm going to keep an eye on the chat for questions, and I will add my single foray into ChatGPT was recently to help me plan a vacation. And I found it very helpful. It gave me a wonderful itinerary, and although not all the information was perfectly accurate, some of it was. But from a professional perspective, I think that across our different clinical backgrounds, wherever we're working, I can really see the value if we can predict who is at risk of developing a C. difficile infection, if we can, if there's any way to work that into predicting urinary tract infections, detecting a viral respiratory outbreak in any of our settings. That's all really helpful information. And then I hadn't really thought about the teaching perspective of it. And I really find that fascinating. If we can use it to help teach donning and doffing, the things that we need to do on repeat, but to do in person can be quite labor intensive. I think that would be really interesting. I'm just going to have a peek at the chat. Oh, Dwayne, our president, says we use ChatGPT on a daily basis when planning our conference. So it comes in very handy. And another Go Jays Go, yay. I can see huge benefits for surveillance. The potential of AI is fascinating. I mean, I think that's really the case. If does anybody have any questions? I think we're all on board with the comments, and seeing how AI is playing out in our day-to-day life has also been really interesting.
Or also any experiences. So if you're implementing AI in your centers already, how is that helping you and what are the challenges? It would be interesting to hear as well. I think they all need their coffee.
Yes, it's early. Well, not really early.
Okay, I've used ChatGPT in Perplexity, which I'm not familiar with. Definitely helpful in some things, but not everything. And I think that's one of the big caveats, right? Don't believe everything that ChatGPT or these generative AI programs tell you.
And it's interesting. I work with the IPAC Canada course, and there have been a couple of instances where I've gone, is this response, did this come from ChatGPT? Did this? So a part of our learning and education too is being mindful. Oh, Dwayne said, oh, can you see the chat, Dr. Sa? Oh, perfect.
I can see it. So I had a hand hygiene slide, which will be in the handout, but I just for time didn't present it. But yes, there are definitely applications for use of artificial intelligence in hand hygiene surveillance as well. Thanks, Dwayne.
All right. Well, if there aren't any other questions, Dr. Saab will let you get back to your Friday. If everybody can hang on for a second, oh, there's another comment.
Yeah, studies showing the impact AI data centers can have on the environment have piqued my interest. I've enjoyed using it and learning how to incorporate it, but it was definitely eye-opening. I think it can be very intimidating. But there are some references that are, again, depending who's written the reviews, it can be quite programming specific, but definitely worth taking a read. And I would say if there are initiatives that are going on in your areas, in your facilities, in your regions, try and get involved just to see what, to become more familiar with it and more comfortable, but also to see how others are thinking about implementing AI, and not just in the IPC world. It could be clinical, it could be in the micro lab. There are lots of studies and projects and initiatives that are going on, I know that you may not even know about. So definitely ask.
Another interesting piece for those of us in Nova Scotia in across the province, we're currently in the process of getting our electronic medical record up and running in December for my site as a starter area. And it would be incredible if we could maximize the AI potential in having this integrated electronic medical record filing in the province and what's possible from that. Because as you said, right now we have very fractioned, siloed systems that don't communicate well with each other. I think it'll be really interesting to see what we can do with our EMR moving forward with AI. I did want to point out the comment about the environmental impact because I think that's something that I certainly did not know about with ChatGPT and AI and all of that are these data housing centers. And it is also good to be aware of and cognizant of the water and electricity that is used up every time we use these centers. So I try to only use my ChatGPT when I have a tough problem at when I learned that there is an environmental component to it. So it is, I think it's something just to be aware of.
Great. Thanks very much, everyone.
Thank you, Dr. Sa.